All right, we'll get started, folks. Good afternoon and welcome to this session of Caregiver Connects. If you can't hear me or for some reason I'm not clear or you have a question or a comment, please feel free to engage the chat box. I am monitoring it and I'll be happy to respond on the fly. Today's topic is, for all intents and purposes, right up my alley. We're going to talk a little bit about hospice palliative care as it pertains to living with cancer. And we're going to also talk about the differences between hospice and palliative care. And I'm going to throw in there a long-term care piece. And the reason I asked Wellspring to speak on this subject is because of the incidences of misinformation, being overwhelmed if the progression of the cancer gets to a point where it is considered palliative, which we'll talk about a little bit more, or incurable. What does that really mean? And how to make a referral to services that involve such engagements as hospice palliative care or long-term care, and how sometimes navigating the system in that regard can be confusing for care providers, caregivers, family, and even the person living with the cancer. So I hope this clears up a little bit today of that and those engagements, because it's a difficult topic. I would find many times it's been a very difficult topic to talk about these aspects of care when you're living with cancer. So we'll get started. Give you a little bit of background of myself, folks. I've been working in hospice palliative care for close to 3 decades. I've worked all across Ontario, into the US and internationally. And it's my passion. Right now at Kensington Hospice, I'm a case manager that provides support, facilitation in groups and one-on-one for caregivers or people providing caregiving, and also for the hospice, where we have a residence, and I provide a lot of the bereavement support, and whether it's group or one-on-one. So I've been at the bedside, and not just at the bedside, but companioning the journey of a life-limiting illness, and in this case specifically cancer. Although hospice palliative care is not necessarily cancer designated, it can be most illnesses, for many years, and I've seen a lot of suffering, a lot of pain, but a lot of joy, and a lot of hope when it comes to the progression through such an illness. Kensington is somewhat of a multifaceted service program. We have a long-term care facility, and we have a caregiver support group. We have a day hospice. We have an older adult support system within what's called the Second Mile Club, which I'm a part of. And of course, we have a 10-bed hospice residence, which I'll elaborate on what that really means. Oftentimes, folks, there's a confusion of what is hospice and what is palliative care, and what happens when you hear hospice palliative care. And does hospice palliative care mean just a structure, beds in a somewhat of a residence, or can it be at home, or can it be in another locales? And I'll definitely clear that up and speak to it, as the nomenclature can be very confusing. For example, what is end of life as differentiated or as a part of hospice and palliative care? Keeping this all in mind, considering that I think it's tonight that the restrictions of stay at home go in place. So I hope you're all keeping safe. It's a very, very challenging time, not just for the general public, but I feel, and that's where my heart and soul lies, and for caregivers and for people who are living with cancer, and the struggles of seeking medical appointments and treatment and services. It's very, very challenging. I see that in the support groups that I facilitate. I have the honor of facilitating here at Kensington Health and at Wellspring. If you're interested, please contact Wellspring. They have their groups online, or you can contact me directly here if you would like to participate in any of our caregiver groups. But it's a very challenging time for a number of reasons. And then if we add the piece of palliative care or hospice palliative care to that, then emotionally, psychologically, psychosocially, spiritually, existentially, it can be very demanding on care providers, caregivers, and family in navigating the system for their family member or their loved one. So everything's going to be kind of referenced in COVID-19 as it seems to have infiltrated all our services. And I'll give you an example of that, folks. So much of our services now is not so much in one-on-one in people's homes and in group settings where we all sit around in the living room here at Kensington or at Wellspring, but in Zoom, right, or in phone calls. So we've had to really stretch our imagination and creativity to continue to provide those services. So what we'll do today, we'll provide an overview of some definitions. I think I'm missing a few points there. Definitions of what is hospice palliative care, what is palliative care, what is long-term care, what is end of life, right? I'm gonna speak to what it means to receive hospice palliative care services, some of the myths around receiving hospice palliative care services, what does it mean to be supported in long-term care, and some of the avenues with which to receive those services, what we call referrals. It's not a simple system, in all honesty, folks. And for someone who even has received an education from a university like myself, I still find it difficult to traverse, let alone individuals like my parents who I caregive for both of them, and my dad is considered in a palliative trajectory. When English is not their first language, to navigate themselves around a system and at the same time experience all that is involved in supporting somebody who's living with cancer, such as the grief and the trauma of it, and the hope and hopelessness and fears and what have you. So we're hoping today's session will provide some clarity and create some kind of connection if you would like to reach out and receive more information from us. So we'll begin with hospice/palliative care. It's interesting because some time ago, 30 or 40 years ago, they were almost differentiated and distinct. Hospice is one thing and palliative care was another. In a program that I helped establish in Trinidad and Tobago in Core Province, there is a distinction between what is hospice and what is palliative care. And in Ontario, there has been an amalgamation of definition and understanding and services provided between the two aspects of this service, hospice and palliative care. You might have noticed, for the most part, we don't differentiate as much. We call it hospice palliative care. Although there's still palliative care in units in hospitals, the services provided within this setting in terms of hospice palliative care is somewhat amalgamated and united. And I'll explain that a little bit further. So in general, what hospice palliative care, whether it's hospice or it's palliative care, is a service that's provided, is services that are provided to someone who is experiencing a progressive, incurable, life-limiting, or life-alternating illness, such as cancer. And when I frame it as such, we're going to frame it in terms of the trajectory of the illness, right? So, for example, some palliative care settings in hospitals or hospices will start supporting the individual who has the illness and what they would define as their family, which was called the circle of care, or the unit of care, at the time of diagnosis. And that really depends on the capacity of the service being provided. Different areas in the province and different hospice palliative care programs will provide different levels of service. Some will begin at the time of diagnosis, meaning we start to support if it's a diagnosis that's considered to be incurable, life-limiting, progressive, then we can provide services then. And I'll speak to those services in a little while. And for some hospice palliative care programs, it's within 1 year, what would be considered and designated, although it's very difficult to really define. I've seen that definition been blown out of the water so many times. Within 1 year of what would be the progression towards death. So it's unfortunately not completely consistent across the province, but the main thing in terms of when we can receive services from hospice palliative care, but the main thing, both in hospices and in palliative care units, or what called PCUs, The criteria is a designation, especially from a physician, as a diagnosis that it's progressive, incurable, life-limiting, or life-altering. But what could also happen, folks, is that, many of you probably know this, is that cancer can progress from it being curable and it go into remission and then return. And in its return or in its progression, become incurable and progressive and life-limiting. And that's an important designation, is that it's a dynamic piece where hospice palliative care kind of can encompass the continuum of the trajectory of the illness. And what we focus on when the cancer becomes incurable and life-limiting and life-altering, is that we focus on palliation. We focus on alleviation of symptoms and signs. We focus on whether it's pain and suffering, which are not necessarily the same thing. We focus on palliation of those symptoms. And what palliation really means is just to decrease in their impact, decrease in the experience of suffering, decrease in the experience of pain, and to support the collateral experience of it. For pain, it can be all emotional aspects, spiritual aspects associated with it. So that's and the palliation part, technically the definition of palliation means to cloak or to cover up. And with respect to symptomatology within hospice or palliative care services, it's to bring down the experience, calm the experience, decrease the intensity and traumatization of that experience, whether it's pain or suffering, as the trajectory of the illness progresses. And that's not just for the person living with the illness, it's for whoever they deem their support network and their family and their friends. We provide many domains of support and care. It's not just pain. It's not just the focus on pain. It's not just, what physically somebody might feel. There's this intersection between the physicality and the emotional, psychosocial, spiritual, religious, existential, environmental aspects of living with cancer, especially an incurable cancer, that hospice palliative care supports. So that's my work. I support, anticipatory loss, or the what would happen even leading up to the death of a loved one and after, which is called bereavement support. Or we have spiritual care that looks at the spiritual, even religious aspects of supporting somebody who's living progressive cancer. Another thing we do, we look at the quality, what would be, and I put question marks this for folks, because we look at, we steer more away from trying to keep somebody alive for the most part, and look more at what they would define as quality of life, right? Although there's a misconception that if you're receiving hospice palliative care services, it means you're not receiving treatment anymore, which isn't necessarily the case, folks. And we'll get into those myths a little bit later. But the focus is on what the person would define as quality of life, rather than prolongation of their life by whatever measures, and specifically focused on minimizing the impact of the disease. One of the most important pieces of hospice palliative care is this idea between autonomy and choice. That's a foundational piece to hospice palliative care. Whether you're in a PCU in a hospital or receiving hospice services, autonomy and choice is a very important aspect of it, meaning to live and die where you want to, for the most part, if it's possible, to have the choice of receiving treatment or stopping treatment, having the choice and autonomy to eat or not eat, to drink or not drink, to change religious ideology or not. And even it goes so far as something called medical assistance in dying, which won't be the topic of the session today, but is definitely a part of palliative care. And one other piece of hospice palliative care, folks, that I really appreciate is to receive services that support the person through their illness, through their cancer that is incurable and progressive, at the location they want, right? Hospice palliative care doesn't necessarily mean it's one place. It could be, and I'm very honored to work with Dr. Nahid Hassani and his team in supporting individuals who live on the streets of Toronto, who are experiencing homelessness, who are experiencing vulnerable housing. right? So that palliative care and some of the tremendous work that him and his team, and including Sasha Hill, focus on is providing palliative care to people where they are, meaning they could be underneath bridges, they could be in shelters, they could be living on the street, or they can be in dwellings that what we call structural vulnerability, meaning they could lose their home at any particular time. And that's an important piece because it transcends to even you can receive palliative care or hospice palliative care in your home, or in a hospital, or in a hospice residence where there are beds people come in and stay with and die there. That's a foundational piece of hospice palliative care, because I hear the stats of where people want to live and die with their disease is 70 to 80% at home or a home-like setting. And most hospice palliative care settings, whether they're PCU or a traditional hospice, are home-like. Home-cooked meals, beds that with quilts on them, soft colors, and the autonomy to watch whatever you'd like on TV. And some examples of what would be considered a palliative care unit as somewhat distinct from a hospice. Although being in the field for 30 years, folks, I've seen palliative care, especially palliative care units, in which would be existing in hospital-like settings or in healthcare settings such as Bridgepoint, and traditional hospices looking more and more like themselves. That wasn't the case 30 years ago. It's very distinct what palliative care looked like in a hospital and what hospice looked like. And now they're amalgamating. They look much more alike, even in their environment, in their structure, and in the services provided. There's more a wraparound encompassing service. So one such facility is Bridgepoint. That would be considered a provision of palliative care in a setting that is not necessarily hospice, but very similar to hospice in terms of its principles, its services provided, its setting, and in terms of the type of care. And that's our facility, folks. That's a 10-bed hospice residence where we provide home-cooked meals. We provide music therapy. We provide art therapy, psychosocial support, funeral planning, and people can stay traditionally across the province, in a hospice setting, in a hospice residence for up to 3 months, 3 or 4 months, and sometimes longer. But the average length of stay in a hospice is usually 11 to 12 days, actually. And it's a lovely setting. It's very home-like. You can bring in your plants, you can bring in your artifacts, and turn the room into a semblance of your home. And of course, there's 24-hour care. There's usually 2 nurses and 1 PSW on for 12 hours a day, even 14 hours a day, and then there's 2 nurses on at night. So it is quite well resourced in regard to into the supports that you receive in a hospice residence. And we prefer to call it hospice residence rather than facility or unit. And that's sometimes a designation, is because you live there, right? Very simply, you live there until you die. The majority of hospices serve individuals with cancer, and there's a phenomenal hospice in Oakville called Ian Anderson House, which is specifically for people and exclusively for people who are living with cancer. And that's what who established it preferred to provide those services for. And then, of course, folks, there is the opportunity to receive hospice palliative care services in your home. So you can have a palliative physician and a palliative nurse, a case manager come to your home so that the loved one can, or the family member can, or even the friend, however we define family, friend, and loved ones, can stay at home as long as possible, right, in a home-like setting, which has been researched and traditionally known to lower the experience of fight or flight when it comes to the experience of living with cancer, and especially if it's progressive and become incurable. And I've heard from many people, folks, that they feel once they've gotten cancer, then regardless of the stage, that it can always return, which could be true for sure, right? But I prefer to support people how they are, where they are in terms of their mindsets. And if their mindsets are keen and open to speaking about such services, then I think it's important for us to engage them regardless of where the trajectory of the illness is. And I can appreciate it's a very difficult conversation to talk about death, dying, grief and bereavement, trauma, and where and when. I'm a strong advocate and I would say trainer or educator, however you define it, an awareness builder from across the province, across the country, even into the US and what have you, of just, even if we don't have life-limiting, incurable illnesses such as cancer, for us to be talking about, what could be called advanced directives, or, our wills, or our choices, when it comes to these aspects of living and dying before the time comes, because I see it a lot when it happens at the time of illness. In any case, you can receive hospice palliative care services at home, and what that can look like, and I'll speak to this in a minute. It can look at as intricately and as professionally as having a doctor, a nurse, and their palliative designation, social workers, and PSWs coming to your home. It could be a hospice volunteer, and just as much as possible to support somebody living with their cancer, their incurable cancer at home. And again, and depending on the services provided, it can be from the time of diagnosis, which a lot of programs have, or it could be up to 1 year from what would be expected of the death. And unfortunately, there isn't that consistency across the province. However, the services are definitely there, and I'm happy to refer what hospices and what palliative care programs do provide those services in terms of timelines. Now, let's speak to this just momentarily. There was at one time, folks, a difference. I get asked a lot, what's the difference between hospice and palliative care? Where does one happen and where does the other happen? And I'd like to speak to it in respect right now, today, in today's social services. They overlap a great deal in their culture, in their style, in their advocacy and provision of services. That wasn't the case 20, 30 years ago. A setting in a hospital that served people who are living with cancer in end stages didn't look anything like a hospice. And I take pride in that. Maybe we influenced the general healthcare system of what it could be like to have hospice services. The locations are somewhat different in terms of hospice and palliative care. Hospice serves people in their homes and in a residence, like a hospice residence, and wherever they define a home, which could be on the streets of whatever city, including Toronto, and palliative care can be provided there as well, right? Palliative care, such as Dr. Nahid Dasani's program, PEACH, Palliative Education and Care for the Homeless, is provided in any location, right? And when we talk about PCUs, or palliative care units, that is in hospital settings, right? Which can obviously look like hospices, and they'll have their own programming in there. So hospices and hospice palliative care units can be very mobile as well in how they travel. So regardless, the model of engagement is very similar now, right? It's not just focused on symptom management and pain and the physical illness of cancer, but on the what's called the totality of the picture. And that's a very foundational piece of hospice palliative care, regardless of the setting that we employ nowadays. And the services offered, like I've mentioned, are very similar, whether they're PCUs or in hospice palliative care, very similar in terms of addressing all the domains of need, psychologically, emotionally, spiritually, existentially, environmentally, physically, in that regard. And then the funding is a little different. That's where it gets a little bit different. For the most part, palliative care provided in hospital settings are fully funded. And hospice palliative care is usually 40 to 50% fundraised. So a lot of hospice palliative care systems rely on communities to survive. And then programs like PEACH are no different, right? They rely a lot on public support to stay afloat in that regard. And then the organizational structures are a little bit different in terms of how they're run, but that's not necessarily thing people want to hear when they have to refer to services, but just to know that they're structured and funded a little bit different. But let's speak specifically to hospice palliative care, right, which what we have here at Kensington Health. Want to make it clear that hospice palliative care is really not a timeline And again, we'll speak to the myths of, of when you want to make a referral to hospice palliative care, it does not mean your loved one is dying imminently. It may not be that they're dying in weeks or months or even years. It's an approach. When we talk about a palliative approach, it's the approach of focusing on autonomy, choice, quality as defined by the person and the family, and the totality of the domains of care, of what the person would receive is in that approach. And it could be almost at any time, depending on the hospice palliative care program, for the most part, at the any time of the trajectory of the illness, of the cancer. That's an important piece, especially if it's incurable. And I've spoken to this. It could be a referral at the time of diagnosis, that they've been diagnosed, or it could be when the cancer has transitioned from either curable but has become designated as palliative. And that could be 5, 10, 15 years out, right? But it's usually at the time of diagnosis of it becoming incurable, progressive, and definitely life limiting. And then it involves these services. Hospice palliative care involves an immeasurable number of services. Well, I shouldn't say immeasurable because we are publicly funded and we're fundraised. But we have a great basket of services, if I can use that terminology. Then one of the most important pieces is companionship. Companionship at bedside, companionship in day-to-day activities, in maintaining a sense of normalcy, and living with cancer for the person living with cancer and for the family members and what would be defined as family members. Hospice palliative care has a strong volunteer component in that regard, and it serves kind of like the continuum of the trajectory of cancer from the time of diagnosis or when it's been deemed palliative, right, incurable. So that we have volunteers who can provide companionship, can provide sometimes shopping, can sit and engage in activities with family members or with the person living with cancer, and can address aspects of anticipating the loss and death of somebody they're supporting. We also have day programs. Many of the hospice palliative care programs have what's called a day program, like we have here at Kensington, where individuals living with cancer come and enjoy activities, right? And play games and visit one another and socialize. Sometimes one of the most powerful things in living with cancer is a peer support model where you are talking to other people and engaging other people who are living with cancer or an incurable cancer, right? And again, we provide the psychosocial, spiritual, practical aspects either in the home or in a residence or in a day program. And one of the most important things about hospice palliative care, folks, is that we focus on the caregiver as well. And however that is defined, whether you define yourself as a caregiver, as a husband, wife, spouse, partner, son, daughter, granddaughter, grandson, or as a person who provides caregiving, because it's not necessarily an identity, right? And I've come across that quite a bit. We also provide help with funeral planning in hospice palliative care, which is sometimes challenging to think of. I know my parents, we worked through that aspect because, I mean, they're not dying imminently, but they may not be here in 5 or 10 years, but we help plan around those aspects, right? And of course, I've mentioned the whole bereavement aspect, and bereavement is the experience of loss, right? And it's a state of loss, but it's not just something that happens after the person has died. I mean, it could happen 3, 4 years before our loved one or our family member dies, as we watch and experience all the aspects of living that they lose. And there's a feeling to that. Loss, it creates feeling. Loss isn't just death related. That's an important piece. Hospice palliative care, that's where it starts to differentiate itself. And it's really about living. It's about living what we define as the person would define and that we're supporting as the highest quality of life that they can and that we can, help facilitate. And experiencing the emotions and traumas and thoughts and mindsets and perceptions that accompany a trajectory of an incurable cancer, which can be 5 years down the road, right? It doesn't necessarily have to be at death. And that's the beauty of hospice palliative care. It really helps people as much as possible to live as fully as they define their lives to be, right? Well before death would come, well before that. And I get frustrated sometimes is that hospice palliative care is always thought of, oh, you're dying when you refer to hospice palliative care. No, we actually help you to live more fully, regardless of when you're going to die, right? It's just that if you have a palliative, incurable illness, such as a form of cancer, we can provide that support. And one of the biggest challenges, folks, is actually in having the conversation about hospice palliative care services. Because there's a number of reasons for it, but the couple of the main reasons. One is this misperception or misconception that talking about hospice palliative care services when you're living with cancer that's incurable or palliative means you're going to die, right? When in fact, it means you want help living more fully with the disease, right? That's really what it means. The challenge is having that conversation is in the awareness and recognition that the disease is going to take someone's life. This is what the person's going to most likely die from, right? And that can bring up experiences of grief, right? And loss of hope and abandonment, what have you, in having that conversation. And we can help facilitate those conversations when we start thinking about hospice palliative care services. But the piece around hospice palliative care that's so important is that it truly helps somebody who's living with an incurable palliative illness, such as a form of cancer, to live more fully, to have an opportunity to express themselves more, or to give the caregiver a break. Before COVID, unfortunately now we're all suspended in this regard, but things happen over Zoom and the phone. We had trained social workers and volunteers who would go and sit with somebody for 3 or 4 hours while their loved one, who's the caregiver or the spouse or the son or daughter, can go out and do something, right? Or just entertain them or engage them or take them out themselves. Right? Those are the aspects, but that can be supported. Just the challenge is that when we talk about hospice palliative care, it's this perception that, oh, I am dying. The disease is going to take your life, but it doesn't necessarily mean a referral to hospice palliative care. It's going to happen tomorrow or next week or next month or even next year. And that's the conversation that we're trying to have for the most part. I advocate very strongly, even teach my 9-year-old daughter to talk about death and dying, to talk about, what is hospice palliative care? What do we want? And how do we engage that? And what are the services that are available there for somebody who's living with an incurable cancer? I'm going to briefly, this is simplified and we can help you with this, folks, but for the most part, to make a referral to a palliative care or PCU, that's usually through a physician, right? But to make a referral to a hospice or a hospice palliative care program, and we call it a program because remember, it's the services provided and it could be in any setting, including a residence. In a residence, it's usually 3 months or less, but at home or in any setting, such as Dr. Nahid Sani's work, it could be almost at any time of the trajectory of the illness. And really, it's as simple as a family member or the individual who's living with the cancer to call the hospice and say, what services do you have for me? What can you provide? Can you support me? What can you support my family with? Or what can you support with the loved one that I'm supporting, who is living with cancer and who that is incurable and palliative. There's also support when it comes to receiving the assessment to come to a hospice residence and make that referral. We help the family member or the individual who's making that referral walk them through the process. Our residents, to come to a 10-bed residence, there's a form called a common referral form through the LIN, which we can help you complete, which we can support you in completing. We can even support in the conversation to even complete that form if that's where the trajectory of illness is bringing us towards a residence, or that's where the person wants to live their last days with their cancer. But just as a reminder, is that hospice palliative care is not necessarily a residence or a place. It's the approach and the programming and the supports and services that we can provide you. The most important piece of this is the foundation of hospice palliative care, and that's autonomy and choice, folks. We want to make sure that whoever is receiving the services, whether it's family members, however they defined, or the person living with the cancer, is that they want it. Nobody who's going to be forced services on them in that regard, and that their choices are supported. So for example, if they choose not to eat, not to drink, or that's more advanced stages, or in the medication in terms of they do not want to seek treatment anymore in hospice palliative, or they want to continue to seek treatment. These are the choices that are respected and advocated for with their care team in that regard, so that they have a voice. They have a voice with respect to how they want to navigate their journey with an incurable cancer. I'd like to also dispel some of the myths, folks, when it comes to hospice palliative care and death and dying and receiving services as such. Making a referral to palliative care or hospice palliative care does not hasten death. It doesn't mean death is near or anywhere near. However, what's important, and we talked about this in the challenging conversations, is that it can appear that because you're starting to talk about a service that is only for people who have an incurable illness, such as an incurable cancer, that will end up taking their life, right? So there is that conversation around sometimes the grief that's experienced, the perception and projection into the future that this is the disease that's going to take my life, even though it could be years away, right? But it does not mean that death is near. It does not mean also that the person's going to die of starvation. Sometimes in hospice palliative care, because of the progression of the illness, people don't feel like eating, especially in a hospice residence. And that's not necessarily that the person's being starved. We provide phenomenal home-cooked meals, and sometimes whatever somebody wants. I'll never forget that one gentleman said to me, and this was just days before he died, he just said to me he had a form of a liver cancer, and the doctors cleared it, and he said, I just want a Big Mac combo. So we got him a Big Mac combo, and he couldn't really eat much of it, but just for him to smell it, to be able to, the aroma, however you feel about Big Mac combos, was ecstatic, right? And that's the quality of life pieces that we focus on. That could be at any time of the trajectory of the cancer. Palliative care, as I've mentioned, it's the myth that it's only provided in hospitals. It's provided in hospice residence, such as our 10-bed residence, where people come and stay for up to 3 months before they die. It could be in your homes. It could be pretty much anywhere, right? Especially in today's dynamic of hospice palliative care and palliative care services. We are trying to find every niche with which to provide these services at any stage of the trajectory of the incurable cancer. Again, it's not the only last weeks and days of life. We want to do what's called early referrals to hospice palliative care, especially for people living with cancer, so that they can have a higher quality of life as they define it months or even years before the disease takes its toll. We educate that, in the palliative approach, that pain medication does not lead to addiction, right? So part of quality of life could be, very good pain management. And I say this sensitively, is that often, not often I should say, but many a times pain management isn't as fulsome possibly, or as appropriate for somebody until they have a palliative diagnosis, right? A diagnosis that they're palliative, or however that's designated. And then pain management, suffering management becomes the focus. And even though they're going to live for another year, 2 years, 3 years, 5 years, however long, that becomes the focus, right? And it doesn't necessarily lead to addiction in that regard. And that's another topic on all itself. Substance use addictions and pain medication. It also, a referral to hospice palliative care services does not mean the doctor or the care team has given up on you and that there's no hope for you. In fact, there can be a flip side to that. And I've sat with people, who have lived for years after having a palliative diagnosis of cancer, is that they have a different form of hope, or more hope in a particular direction. Or they have a different quality of life, that it's all focused more on autonomy and choice and living the way the person expresses themselves fully than they'd ever have in their entire lives, right? So there's that aspect of it. It also doesn't mean treatment stops, right? People can receive hospice palliative care services and still have curative measures, still have treatment options, can still receive for example, radiation to untether a tumor, right? That's pinching on a nerve and causing a great deal of pain. It's a myth that treatment stops, folks. What I'm trying to say is that approach. Hospice palliative care is an approach to somebody's trajectory of illness, right? And all that encompasses in terms of the services. And also, once you enter in a hospice palliative care program, it doesn't mean you can never leave again, right? And I've had the absolute privilege and honor of literally seeing, and this is not to give false hope or the advocate for miracles or anything, though. I mean, that's your prerogative if that's what you believe in. But I can't tell you how many times I've seen people come to a hospice to die and 2 or 3 months later walk out of the hospice, right? Walk out of the hospice residence. Or have expectations of dying within 2 or 3 months and living for 2 or 3 years. And what that speaks to, folks, is the power in treating somebody as an individual with dignity, honor, respect, unconditional love, compassion, good pain management, good suffering management, access to services. It's amazing what it does for the human spirit to live, to engage in aspects of life, to engage in aspects of self-expression, to support those around them that are part of that trajectory of that illness. It can do wonders. So you're not held hostage in a hospice residence or in a palliative care unit. Sometimes people come and they stabilize, they go into remission, or they would rather just return home to die or to live. I mean, I've seen remarkable things, what I would classify remarkable things. I mean, I think the process of death can be remarkable as well in how the person engages in and defines it, and the family and what have you. So coming to a palliative care unit or hospice palliative care or receiving the services doesn't mean you can't leave, when at any time. It also doesn't mean you give up on life, right? And that's an important piece, is that sometimes, folks, and many times I should say, engaging in hospice palliative care services can be engaging in life even more. And I have to tell you, I've sat with individuals who have said, I've never lived more in my entire life since I engaged in palliative care services. And I'm not going to die for a couple of years, but it's helped me to live my life more fully. It helped me to my self-expression, my spirituality and religiosity, my family dynamics. It's helped my partner or my caregiver, because they have some more supports and they can be heard and they can have somewhere to put their grief and trauma and loss at what's happening to me. It could actually it's not necessarily giving up in life. It's actually sometimes engaging life more fully. And it doesn't mean we've given up on your care. I love hospice palliative care, folks, because of the capacity of services that come forth when somebody has a diagnosis that's palliative. Unfortunately, there's a tragic side to that. I'll never forget this gentleman who had spoken to Dr. Dasani and told him, why did I have to give up? Why did I have to be dying for somebody to give a hoot, right? Because the services in hospice palliative care, especially in how they're wrapped around and how they're encompassing with all the domains, are usually more than any services of anybody with a chronic or an acute illness, right? And that's what I'm trying to say is, in hospice palliative care, you oftentimes get more services and more care and more opportunity to receive care than pre-diagnosis of an incurable cancer. You don't necessarily need a doctor's referral to receive hospice palliative care services, especially with services that are provided in the home or over the phone, or what would be called community program. And another myth that hospice palliative care is charged. You pay for it. In the States, you do. If you hire private care in Canada, such as a death doula or social workers, what have you, you could pay. But for hospice palliative care services, it's not. It's actually free, right? It doesn't come at no cost, because we have to fundraise and the government gives us some money as well. But it comes as no charge to you. Okay, so that's an important piece. Now we're going to speak a little bit towards, we're going to speak a little bit towards long-term care, folks. I have the absolute privilege to work in a facility where we have a long-term care, and there's a lot of, how can I say, negative media on long-term care, but I'm very proud to be in a long-term care facility where we have very strong ethics and integrity and morals and values and services and care that's provided for our residents. So yeah, I'm just putting that out there because of a lot of the attention that is on long-term care facilities, which in many ways it's justified, but also I see the other side of it where we provide exemplary care here at Kensington Health. But in that regard, a lot of long-term care folks is individuals who are in a palliative approach, right? We use a palliative approach all over the long-term care. People have chronic, long-standing, incurable illnesses such as cancer, and they live with us for years. But it's the approach that we provide for them that helps them live more fully. Long-term care is usually individuals who are adults and predominantly individuals who are older adults, but we provide 24-hour nursing care. But the wraparound service that we provide is very similar to hospice care, palliative care, because we've infused it with a palliative approach, psychosocial support, creativity, music, art, religion, spirituality, the physical practice like assistance with activities of daily living, which we term as ADLs, such as eating, bathing, toileting. All those aspects are in that encompassing care. And then we monitor for safety and well-being. And well-being isn't just physical, right, folks, especially when it comes to cancer, which can also, for example, brain tumors can lead to aspects of dementia and cognitive impairment. But however the person defines well-being, which is emotional, psychological, individuality of that person. The difference with long-term care, there is a charge, whether it's for-profit or not-for-profit, where it's subsidized by the government. There's a charge for it. Again, there's not-for-profit or public funded and private long-term care facilities. And then, of course, we're lucky because we also have the hospice in that. So there's quite a continuum of care. You have the long-term care, day hospice, you have community support, you have second mile, and then you have the hospice residence beds, and then you have bereavement and caregiver support. So that's the model, really, that really I find works in providing a suitable amount and volume and capacity of care to the general public. Now, something I wanted to differentiate quite clearly, folks, especially for somebody who's living with cancer, that's transitioned to being palliative or incurable, is something called end of life. Now, end of life is not synonymous with palliative care or hospice palliative care. It's a part of it, but it's not synonymous, except people, many times you hear, even colleagues, even frontline providers, and even physicians, often physicians, is that there's this interchangeability between palliative care and hospice palliative care and end of life. And that's not true, okay? It's a part of the stage of hospice palliative care, but it's a very small part of it. For all intents and purposes, when something's deemed end of life, it's the last 3 weeks of life. Whereas hospice palliative care can be the next 10 years of life, right? It's the approach, right? So end of life is a part of that, but it is not synonymous. When we say end of life, it doesn't mean hospice palliative care. And so why I bring that up is that oftentimes when somebody's living with cancer, when we talk about hospice palliative care, sometimes even frontline providers such as physicians and nurses, but oftentimes families, they're like, well, I'm not at end of life, right? I'm not dying. Well, it's not synonymous with hospice palliative care service. It's a part of it, right? But it's a small actual part of it when we have all these services, because we want to focus on somebody living as fully as possible as they define their quality of life. There can be aspects, just to clarify, it can be aspects of when we do deem somebody, and when somebody enters what would be defined as end of life, which is very challenging to even define. That's when I said it's less than 3 weeks, that's the textbook definition, right? Especially in nursing practice. But folks, I've accompanied people right until end of life, where you wouldn't necessarily define them as end of life, meaning they're not so much eating and drinking. They may have stopped eating and drinking. They're usually bedbound, or they don't have much activity, or they might have lost consciousness, or they're not communicative. I sat with people right up until the time of death, and they're communicative, they're moving around, they're eating and drinking, and their life ends, right? So however you define that, or however you give reasoning for that. So that's why I love hospice palliative care, is that you see so much life, right? And I want to advocate for that with individuals living with cancer, because I feel like it can definitely enrich their lives as they receive services at any time of the trajectory of the illness once it's designated incurable or palliative. How to make a referral to long-term care folks? It's through the LIN. There's a specific process where they are case managers there, care coordinators that support the application to long-term care. There's also tours of long-term cares that are virtual now. You can call the long-term care or call someone like myself to facilitate the referral to come to long-term care. And then, of course, we have caregiver support, a lot of caregiver support and family support within long-term care. But I wouldn't be off base by telling you long-term care, most of the people living in long-term care are in a palliative approach or have some aspects of palliative care to them, if not 80 to 90% of them, because their trajectory of whatever they're experiencing is limiting and altering their life. But the approach is there. And that's really the future of healthcare when it comes to living with an incurable, life-altering, life-limiting progressive illness. Now that's a mouthful, is to provide a palliative approach that focuses on dignity, integrity, autonomy, choice, symptom management, the totality of the domains of care, right? And it's just approach, right? This feeds back, folks, to the aspect of having the conversation. In having a conversation, whether it's catalyzed by or initiated by the person living with the cancer or care team of physicians and nurses and social workers and what have you, or by the care provider or caregiver or family member, these are the experiences that can happen when we start talking about hospice palliative care services, just because of how it's equated to the inevitability of the disease, of the consequence of the disease or the result of the disease, which is death, right? Regardless of how long forward that is down the road. There can be experiences of guilt, right? Whoever is bringing the topic up or whoever wants to make the referral, there can be experiences of guilt in that they're giving up on the person, or they're removing care, or they think they're dying. So they're making this referral to hospice palliative care. And I bring these emotional impacts to light, folks, because if you do have the conversations with your loved ones, these might be emotional experiences that surface in having that conversation. And sometimes I work with individuals or family members or the person living with the cancer in how to navigate the conversation in making a referral to such services, or in how to manage and support and facilitate the emotional experiences in the conversation itself. Because there'd be also experiences of abandonment, right? Well, you've given up on me, that I'm dying now because you're referring me to hospice palliative care services, or that, you know, I'm leaving the family to receive services from hospice palliative care. For example, I can't tell you, folks, I've been in this field for 30 years, over that now, I'm dating myself. When I was a volunteer at a younger age, I'd visit family members, and there would be such a connection between myself and whoever I was supporting that sometimes, because of that referral and that support, other family members would feel out of the circle or abandoned. And that needs to be supported, right? Because they're so used to being necessarily in connection, and then person who's whoever wants to talk about these experiences can always speak to others about it, especially if they're living with the illness and with the cancer. They want somebody else to talk about it and that can leave others feeling abandoned. There can also, especially in different cultures, different demographics, different social economic backgrounds, like my community, right? My ethnic community, is this responsibility that I should be caring for my parents, and I shouldn't bring in any other services such as hospice palliative care. And that's a responsibility, a sense of responsibility that was bestowed on me that I've challenged with and I work through, because the services are something that I would never see in my parents' home country or country of origin, we'd say, because I feel that although they don't talk like this, I talk like this, that their home country is Canada, although they talk about the homeland, as some of you might be aware of in your circles. So there's this sense of responsibility, right, that has to be sometimes engaged. Or there could be a fear, right? what would the services entail? What would they mean? Or would you talk about death all the time? Or what if they don't want to talk about it? Why don't they talk about the Leafs not winning the Stanley Cup, which they never will, right? I mean, sorry, Leaf fans. There's these aspects of it that can be brought. There can be a great deal of anticipatory grief way before somebody ever is succumbs to their illness, or their illness is taken to the point of death. There can be all the losses that are experienced in that can be supported in hospice palliative care. There can be a sense of isolation and loneliness that can be experienced either by the caregiver, the family member, or the person living with the incurable cancer, or the cancer that's being palliative, in experiencing that aspect of it, right? Of what this disease is going to be doing to me. And there's an isolation and a loneliness to that feeling that can be supported by someone in hospice palliative care. It can also provide a sense of purpose. It can reshape or help to reshape and facilitate what can be defined as hope. And sometimes a referral to hospice palliative care services can be a relief. One, that what has been the elephant, quote unquote, the elephant in the room, has finally been spoken about, that this disease is going to lead to death sometime down the road, right? However that long that can be. And a relief that there's going to be some support now, that we're preparing now for something that might happen a year, 2 years, 5 years down the road. Or that finally that this person can talk about something that they've never been able to talk about with their family members, right? Which is, the inevitability of the course of their disease, right? Or the caregiver can talk about that, which they can't necessarily talk about with their loved one who's living with the illness, who is still focused on curative measures, right? So there's all these emotional aspects that can be supported in hospice palliative care, especially as a consequences or collateral of the discussions that could happen. I think that's a good amount of information for today, folks. I love hospice palliative care because I really feel, and I've experienced it and I advocate for it, and I hope I say this sensitively, for how much it can help us to live more fully, almost regardless of the trajectory of the illness, right? So my contact information is there. I'll be happy to answer any questions, help with referrals, talk a little bit more about, services, or even about the whole spectrum of living and with a life-limiting, life-altering cancer that's incurable and could benefit from a palliative approach. So please stay safe out there. We're at stay-at-home emergency measures, and I hope you all stay well. Take care.